Okay, so the topic of today's class is renal tumors, and I'll be covering it in two parts. So this is a part one of the renal tumors class. Please mention your doubts in the chat box so that I can address them. And remember, this is a two-part lecture. So today we'll be talking about the benign renal lesions. So today we'll talk about benign renal lesions, and tomorrow we'll talk about the malignant renal tumors. Okay, so let's just first start with the introduction. Now, whenever we talk about the renal mass, and one more thing I want to clarify today, that we'll be talking about solid renal tumors. Okay, cystic renal tumors will be a separate class. I don't want this class to be lengthy, so I've taken cystic renal tumors in a separate class. This is a class on your solid benign renal tumors. Okay. Now, whenever we talk about renal masses, first we have to learn how do we acquire a renal mass protocol, CT. Okay, so remember, for any renal mass, for its diagnosis and its staging, CCT is the investigation of choice. So CT is the investigation of choice as far as your renal masses are concerned. Now, what is the CT protocol that we follow? Okay, so CT protocol consists of your four phases. So first is a non-contrast scan. Now, non-contrast scan is taken from diaphragm to your iliac crest. Basically, the idea is to cover the entire kidneys. Now, you can let go of this non-contrast scan. You can let go of it if you have dual energy CT. If you have a dual energy CT scanner, then a virtual non-contrast can be acquired during with the help of your arterial phase CT as well. So if you have a dual scanner, you don't need to take a separate non-contrast CT. Now, for most of the places in private, dual energy scanner is not available. So they have a normal 64 slice, some have 128, some even have 256. But in private centers, in private establishment, most of the places you'll see a 32 or a 64 slice CT. Because, for a 128 slice CT, the price suddenly jumps to 2.5 crores. So not a lot of private centers can afford that unless they are like a big chain. So most of them start with a 32 or a 64 slice scanner. So a non-contrast scanner, non-contrast phase followed by a corticomedullary phase, followed by a nephrographic phase, and finally a excretory phase. Now, when are these phases taken? So corticomedullary phase is taken 30 to 40 seconds after your contrast injection. So take it as sort of a late arterial phase. Okay, late arterial phase 30 to 40 seconds. Now this 40 seconds, okay, this 40-second arterial phase, remember, this has a lot of similarity with other CT protocols. So this is your late arterial phase. Now this is useful in HCC when you are doing a triphasic CT. This 40-second is also the timeline when your enterography is acquired. So your bowel enhances maximum at 40 seconds. This is also a phase in which your pancreas maximally enhances. So pancreatic phase is also taken at around 40 seconds. Okay. And portal vein opacification is also maximum at 40 to 50 seconds. Slightly later, enterographic phase is 40 seconds. So slightly later than that, your portal vein also opacifies maximally. So remember, whenever some abnormal type of phase, corticomedullary, pancreatic, enterographic, such phases are asked, a ballpark figure to remember for your exams will be a 40-second timeline. Now, next phase is a nephrographic phase. So what happens in corticomedullary phase? This is the phase when your renal cortex maximally enhances. Okay, it is taken 30 to 40 seconds after contrast injection, or if you're following a bolus tracking technique, whenever the trigger reaches 150 HU, whenever the attenuation in the descending aorta reaches 150 HU, your trigger is started, and after 10-second delay, you can acquire a corticomedullary phase. Now, nephrographic phase is again taken for the whole abdomen. So non-contrast corticomedullary phases were taken for the upper abdomen. So from mid diaphragm till your iliac crest, but nephrographic phase, take it as a venous phase. Okay. So it will be for the whole abdomen. So starting from your mid diaphragm all the way till your lesser trochanter, your nephrographic phase will happen at 100 seconds from contrast administration. And then finally, we take a excretory phase in which there is a pacification of the pelvic glacial system and the ureters. So this is taken at around 12 to 15 minutes after contrast injection. And again, this is your whole abdomen scan because we want to image the kidneys, ureter, and the bladder. So all these will be your whole abdomen scan. All these will be your whole abdomen scan. Whereas your non-contrast and corticomedullary phases will be your upper abdomen scans. Okay? Now, why do we use different phases? Why do we use different scans? So unenhanced CT is used to see, as we all know, for calcification and hemorrhage. So for fat, hemorrhage, and also calcifications, we use a non-contrast scan. Now, corticomedullary phase is sort of a late arterial phase. So we want to see the vascularity of a tumor, whether it is intensely enhancing like a clear cell RCC or an angiomyolipoma. That will show maximum enhancement in your corticomedullary phase. Now, nephrographic phase is sort of a venous phase. So we want to assess the washout, if any, or we want to see any vascular invasion. So for example, renal vein involvement and lesion characterization in general. Now, delayed urographic phase is used to see the relationship of the tumor with respect to your pelvic glacial system so as to assess your resectability. Okay, so renal pelvis involvement or ureteric involvement, these all things are judged on your delayed urography. Okay. Now see how important nephrographic phase is. Actually, nephrographic phase is the one phase in which we actually see the renal mass. We don't see the renal mass in corticomedullary phase on your CT scans. So see this image on the corticomedullary phase, we cannot really appreciate a mass, but on the nephrographic phase, when the cortex and the renal medulla both have approximately same attenuation, then we see an abnormal hypodensity corresponding to a mass lesion. So that is why, nephrographic phase is the main phase in which you see the mass. To assess the vascularity, you see the corticomedullary phase as well. Now, broadly, the lesions of the kidney can be divided into three main types. So it can either be a cystic tumor, which you will read in separate class. It can be a solid renal mass. The prototype of a solid renal mass is your RCC. So I'm writing SRM or solid renal mass. And the third type is an angiomyolipoma. Okay, angiomyolipoma is one of the common benign lesions of the kidney, and they occupy a significant chunk. Now, solid renal masses, apart from angiomyolipoma, can include a differential diagnosis of these all things. So, if you're asked in the exam, differential diagnosis of a small renal solid mass. Okay. Small renal solid mass definition is less than 4 centimeters. So any solid renal mass less than 4 centimeter is classified as a small renal mass. And the differential diagnosis include RCC, oncocytoma, minimal fat AML, transitional cell carcinoma, lymphoma, METs, infection, and infarction. Okay, so you can take a screenshot of this image. This comes in handy when you're dealing with differential diagnosis in the exam. Now, the benign lesions of the kidney can either be cystic lesions, benign tumors which are solid, or infections. So, for example, you can have focal pyelonephritis, right, which can mimic an infection. You can have tuberculosis, which can mimic a tumor. You can have sarcoidosis of the kidney as well, which can mimic a tumor. So these are all benign lesions of the kidney. Now, whenever we are seeing any renal lesion, first thing to do, the step one is differentiating between cystic and solid lesion. Now, how do we define cystic and solid? So a cystic lesion either has no tissue component is less than 20%. Now, what does it mean? For example, if this is my kidney right? And I have a lesion in the upper pole, which has also solid component within it. Okay, so will I call it a solid renal mass with cystic degeneration or with necrosis, or will I call it a cystic renal mass with a solid component? That depends whether the volume of the solid component is less than 25 or more than 25%. So if it is less than 25%, then I'll classify it as a cystic renal mass with a solid component. Okay, very, very important point.